In order to successfully scale new ideas in healthcare, it's helpful to understand why some ideas fail. And there's much to be learned from the journey of a really important clinical innovation, namely the lemon. And so in the 1700s, scurvy was a significant cause of illness and mortality amongst sailors. And the economy at that time was really determined by maritime trade. And so it was a costly problem. In 1734, a British physician named James Lind launched one of the earliest clinical trials where he found that lemons were really effective at treating scurvy. And so you'd think that because scurvy was such an economically costly problem and lemons were such an elegant, easy solution, it would have been widely adopted quickly. And it wasn't. So it took 50 years for lemons to become common practice on naval ships in the UK. And Lind didn't actually live to see this. And so why did it take 50 years to scale? So firstly, Lind published his findings in a 450-page treatise that were full of a lot of philosophy and not a lot of clear practical recommendation. He didn't have relationships in the administrative ranks of the Navy. There was a solution preferred by Captain Cook that was a sham solution, but Cook was an influencer of his day. And finally, even amongst early adopters, the model wasn't clear. People were boiling lemon juice to save space on ships, rendering it ineffective. And so I think it's tempting to think like a lot has changed about science in the last like 300 years. And that's true, but it's not. And empirical research shows that it still takes about 20 years between discovery and widespread adoption of promising new models in healthcare. And so I think the obvious question is what's to be done. So I think we can learn a lot about or from the emerging field of implementation science, which really provides empirical evidence about how do we shorten the discovery uptake gap. And at Bridgeable, we help our partners to do this by broadening the scope of research to include data and instruments that capture things like barriers and facilitators to implementation. We focus on building strong networks early on so we understand resistance to ideas and we build buy-in. We use design thinking to build dissemination strategies around the needs of end users, so policymakers and healthcare providers, not funders. And finally, we've really focused on easy access to information for early adopters.